for those couple of you that just signed on, go ahead and tell me who you are and where you're practicing. All right, so go ahead. Those of you who signed on, go ahead and announce yourself, and I'll put some check marks here on my registration list.
This is Elizabeth.
Morning, Elizabeth. Welcome back.
Yes, thank you.
Am I muted, or can you guys hear me?
I can hear you, whoever that was.
Okay. This is Kirsten, pediatric dietitian with UNM Renal.
Good morning, Kirsten.
Hello.
Good morning. This is Kristen Cody from Sejosa Medical Center in Fort Defiance, Arizona.
Okay, say your first name again.
Kristen.
Okay, good morning.
Good morning.
Anybody else?
Good morning. This is Gail Zoolander with the Sioux Tribe in Michigan.
Good morning. All right, so my guess is we have a few more people registered, so you'll hear that little chime where people join us, and then I'll at some point ask for roll call again, so you can announce yourself. For those of you who haven't participated with us before, mute your phones when you're not speaking or don't have a question, just because it's morning, so I know you're like me and you have a cup of coffee, you might have a breakfast burrito, you might be paging through the charts on your desk. So all of those things get magnified in telehealth. So it's the *# to mute and unmute. I'm very much open to questions, so don't feel shy about asking questions. I don't want to be the keeper of the knowledge. I'm here as a facilitator to bring to the attention of folks taking care of children from the nutritional standpoint, topics that we all need to be thinking about and can share our experiences. And so I have a really wide group of people who are practicing in a varied number of places this morning that are on my registration list, so I hope to learn a lot from you all this morning. So, oh yes, I'm going to introduce the folks in the room too. We have 2 new attendees at Studio Envision, and I'm, as the speaker, disclosing that I have no disclosure. So in the room today at Studio Envision, the name we have for our telehealth room, I have with me.
Hi, good morning, Courtney Acklin. I'm one of the new QI coaches.
And I'm Sarah Anderson. I'm also a QI coach.
And also Kevin Whirling, systems analyst, IT person here at Envision, New Mexico.
So up on your screen, for those that this really only applies to the New Mexico folks, Molina Healthcare is a Salud or a Medicaid provider here in New Mexico, and they offer reimbursement for providers who present patients that can be discussed among the providers present in any of our telehealth clinics. So if that applies to you, this slide's going to be important, but it's quite a large reimbursement. It's $150 the next time the patient comes into your clinic. So I think it's important to keep that in mind. All right. So what we're going to talk about today is nutrition diagnosis in pediatrics, specifically using international dietetics and nutrition terminology. And for those of you who are dietitians, you'll know that in 2005, the Academy of Nutrition and Dietetics, then called, I can't even remember what it used to be called, American Dietetic Association, decided that they would adopt wholeheartedly standardized language for communicating nutrition diagnoses in the medical record. And it's not a new concept. Those of us who work in clinical areas know that nurses and especially physicians use diagnostic terminology all the time, and we're very comfortable with that. ICD-9 terminology is what we think about in the medical world, but that is to be only used by physicians, nurse practitioners, and PAs. So it's not terminology that we can adopt. So the idea was that we needed a way in which all of us were communicating the work that we did in the same way. So it was designed not so much to change the way people practice, but to clarify the practice that we were involved in. So that's the place that we start. The idea was that we were going to have full adoption by the end of this year. And those of you who are working in the field, some of you may be in places where that's the case. Everyone in your facility is fully adopting use of this diagnostic terminology. And some of you may be in places where it's just something that you're beginning to learn from maybe the interns that you precept as they come through their internships. So that's the background for thinking about terminology. And again, it was not necessarily designed in the beginning for pediatric populations. So sometimes those of us who are practicing in pediatrics need to think about how we apply that to this special population. So the questions that I want you guys to think about this morning, and we can come back to these and discuss these, is have you adopted the International Dietetics and Nutrition terminology in your practice? And how are you currently incorporating that, specifically using the problem etiology and signs and symptoms, or PES statements, in your charting for pediatric patients? What benefits do you find of incorporating IDNT, PES statements in documentation? And if you haven't done it, can you think a little bit outside the box, after our discussion, or maybe perusing some information before or after this session, how that might benefit the work that you do? And is adoption changing the way you assess and treat patients? So I think this is a real great question for us to come back to. So the whole reason of using a nutrition diagnosis is to give it a specific name. And all of us have done this. We've called things by certain names. Each of us has our own list of terms that we use frequently, especially if we're working in a population that's very, very defined, of kids that may have a specific disorder or might have a specific common diagnosis, ICD-9 diagnosis. So we tend to use the same terminology over and over again. However, has not been standardized across all people who practice in those areas, and maybe all people who practice in the same institution. So it does mean that people have to read notes very carefully to get at what the provider is actually identifying as the issue. So the nutrition diagnosis very, very clearly identifies and names the specific nutrition problems that are discovered from the nutrition assessment. So keeping in mind that you can have more than one. So it's not limited, you only have to pick one. You can have multiple diagnoses, but you are giving it a very, very specific name. This diagnosis then becomes the missing link between the assessment piece and the intervention. And more importantly, it describes the specific nutrition problem that the RD or the dietetic technician registered are responsible for treating independently. So it's not a medical diagnosis, so it's not an ICD-9. Though you will probably be working in a situation where a referral comes to you from a primary healthcare provider in which the ICD-9 is the presenting diagnosis. So that's the place in which you're working, and it is the place in which you have to tie your billing to. However, it is not the thing that you might find is the real issue. It's just the referral diagnosis from the PCP. So there are three general domains in nutrition diagnostic terminology. So one is intake, and that describes excessive or inadequate intake compared to requirements. So either actual intake or estimated. There's the clinical domain where we relate medical or physical conditions that are outside what we consider a normal or typical range. And then the behavioral and environmental domain, which relates to knowledge, attitudes, beliefs, physical environment, access to food, or food safety. So those are the three big chunks that we sort of take out of this very large array of things that we could find are issues with the patients and families that we serve. So the newest edition is the 4th edition. There's a picture here of International Dietetics and Nutrition Terminology. It's a yellow book. I actually have in front of me both today, the new one and then the old one, which is the 3rd edition. The only thing that I can say about the difference in the two is that the newer one has an expanded list of diagnostic terms, because this is meant to be, if you actually read through the manual, it's meant to be a living document in terms of as things change and as terminology might not work as well as it was originally designed, and as researchers actually try to link diagnostic terminology to outcomes and interventions, they may find that some of the terms are somewhat clunky or that we're missing some. And so the idea is that probably every new version there's going to be things added or things taken away or clarified. The sheet that you got as a reference actually comes from the 3rd edition. And the reason I did that is I figured that was the one that probably most people had. So there's that one page in your handout that has all of the terminology, the diagnostic terminology. The cool thing about owning the book is that you actually can look in a particular diagnosis, and it gives you some tips about what you should be looking for under each one of the assessment categories. So that's helpful from a teaching standpoint, but it does get to be a little dry reading if you're not in the mood to do that. The other thing that you should know is that diagnostic terminology is only one of the things in the nutrition care process that now has terminology associated with it. Assessment has terminology, diagnosis has terminology, intervention has terminology, and so does the follow-up and evaluation that has terminology associated with it. But the diagnosis, of course, is the key, and it's the thing that we need to be most consistent in trying to address as a profession. So, the other thing that happened with the adoption of this terminology was the idea that we had to use some kind of standardized charting. And we all have been exposed to multiple kinds of charting, ADIME, PI, SOAP. I mean, depending on whatever system your hospital or clinic uses, you might be using electronic medical records, you might be using paper charts, you might be using standard forms, but we all have some kind of format in which objective data from the family, assessment data, and our plan for the family goes. When we use diagnostic terminology, it needs to be used along with a PES statement, and this is the problem etiology, signs, and symptom statements. And as someone who's been doing this work for a long time and actually working and precepting interns for a long time, this is really fantastic because it makes it so easy to help a student narrow down how they're going to approach something because there is this structure. So the problem is that, again, that diagnostic label, and that's what we're talking about today, describes the alteration or the issue related to the client's nutritional status. And that's the standardized stuff that we're using. The etiology is the cause or contributing risk factors. So one of the things that we need to do at this point is work to describe the root cause, because there can be many etiologies for a particular diagnosis. Some of those are going to be within the realm of things we can work with the family on or fix, and some aren't. But usually there's something that's the base of all of that problem. And we try as much as we can to get down to the root cause. Because if we do that, a lot of times some of those other things will sort themselves out over time. And the signs and symptoms, they're the defining characteristics. And usually those come from your assessment data. And they can be used to monitor the nutrition intervention. So when you find a problem, you decide what you think is the root cause, and you have some things from your assessment that are outward and visible signs of that problem. If you are successful in your intervention, those signs and symptoms should move. They should change. So they're things that you can actually measure. So all the terms listed on your handout from the 3rd edition can be used as the problem. You don't need to use the associated numbers. However, as we move to using more global use of EHR, and I see that it says her on there, I tell you, spell check just couldn't live with that. So I gave it didn't pay attention, so it changed it to her instead of EHR. These will be one of the required fields. So like physicians, nurse practitioners, and PAs who use standard terminology all the time, they memorize those numbers not because they set out to do it, just because it happens over time. So you are going to find those in your EHR fields so that the numbers will be something that can be pulled out of a database to talk about what's going on in your practice. But in writing longhand or typing into a medical record, you're going to use just the words. But we want you to use the words the way they are in the text because that's the whole idea, standardized terminology. Some terms can also be used as the etiology. So in other words, if you like the way something is said, you could also put it in the etiology piece along with something else. But you can also use free text at that point. And some terms can be used as signs and symptoms. as long as they're accompanied by that actual data. And remember, we're talking about actual data. This is the stuff that we can measure. So these are the things that we should be able over time to see a change. However, you can also have free text there too. Nutrition assessment data must be available to support the selection of the nutrition diagnosis. So again, using that PES statement, you can't just make a wild guess about what's going on. You're going to have to, because of that structure of that statement, have to include the etiology and the signs and symptoms. So you're sort of locked into that, so it's not really going to be a point where you can't support your nutrition diagnosis. However, if you get to the point where you're thinking about a term and you think you've got it and you get down to that point and you don't have anything to support what you think your problem is, then that should probably tell you that you need to look somewhere else. It must be specific enough to be able to show improvement when an intervention is started. And again, we've talked about the signs and symptoms being able to be the thing that we measure and move. And we've talked a lot here about my approach to nutrition assessment, which is using the ABCs. And of course, we go all the way to F in pediatrics, which looks at the feeding skills and development. But if you put all of your assessment data into that ABCs, you'll actually have things that you can pull from all of these diagnoses. So when you document the diagnosis, so we've got two parts here that are new for adoption. One is using that standardized terminology, which we were all supposed to be using by now. And just so you know from the literature, we're about not even 50% in some places. Now, some systems like the Veterans Administration have adopted this pretty much across the board. And part of the reason is once you get people buying into it, any new employees that come into the system have mentors that they can work with. So they fairly quickly get up to speed on how to use this the way they should. But a lot of systems aren't doing that. So you're anywhere from 0 to 50% for everybody else. Using this particular format, again, forces you into making sure you've got all the pieces. So this is the format. You have your problem, which is your standard terminology. That's the P. Related to whatever that root cause or that etiology is, as evidenced by whatever the signs and symptoms are. And that's exactly how you write that statement, that sentence. And you can see how you might use this in all kinds of other situations, because it's not a unique way of defining a problem, but in our case, it's the way that we are asked to do this. So at this point, I'm going to stop and just see if anyone has any questions on what we've covered so far, and then I actually have some cases for us to go through to see if we can't pick through some of these things, because we can talk about using standard terminology, but the best way to get good at this is just to practice and have other people comment on their approach to the same case problem. So it's *# to unmute yourself. And if I've already put you to sleep in the first 15 minutes, I apologize.
And this is Kevin. There's a potential that I have muted you from here. So if you do need to unmute yourself if you're talking and we're not responding to you, we're not being rude, I swear. We just can't hear you. So you may need to hit *# to unmute yourself.
So we have to be comfortable with silence at Studio Envision. And I actually have to watch the clock to make sure I don't jump in and talk too fast. It's one of my faults. Okay, so what we have in front of us is a case study. And you should also have in front of you your list of diagnostic terminology. I'm thinking that Courtney and Sarah are going to be at some disadvantage here, having not been exposed to this before. But I bet you can make a stab at it, because both of them are healthcare providers, just in different fields. So my guess is this is not going to be completely outside a realm of possibility for them. So our practice case study is an 11-year-old male, BR. He has a history of peanut allergy. He was diagnosed before the age of 7. And he was referred to us, the collective of registered dietitians, for decreasing growth velocity by his primary care provider. And I've tried to set these up so you don't have any math to do, because that takes time and we don't have as much time in telehealth. His weight is 34.9 kilograms, which puts him at the 28th percentile. His height's 146.8 centimeters, which is the 49th percentile. His BMI, raw BMI, is 16.2, which puts him at the 24th percentile for age. His BMI at age 8 was 16.6, which put him at the 67th percentile. So age 8 was 67th, and BMI currently at age 11 is 24th percentile. From the other side of our assessment data, BR refuses family meals. He makes his own. There is concern by BR that he's not physically fit and that he might have an allergic reaction. His mother reports that BR is restricting intake beyond allergy control, so she thinks there's something else going on. Based on his 24-hour recall, he's consuming 1,636 calories and 66 grams of protein. Some of that is contributed by 8 ounces of Ensure that he consumes every day. His estimated needs are 2,277 kilocalories and 33 grams of protein. So that's what we have for our case. So on the next page, what you've got is just that little format for coming up with the diagnosis. So what I want you to do, realizing that there will be silence here, for case 1, there's the handout for the IDNT codes from the 3rd edition, which you had attached to your handouts. Or if you have your book in front of you, you can use the 4th edition also. Let's take a stab at a couple of diagnoses here. And you can have more than one, you might have 2 or 3, but let's take a stab based on the information that we have from the case. And I'll give you a couple of minutes, and then let's have a discussion about what you all come up with. The other thing I need to point out, and all of the folks who are on today are all credentialed people. It doesn't appear that we have any students. But there's no right or wrong answer, and this is one of the things that I talk to the students about all the time when they're working with families. All of us come to a situation working with a family where we have a set of information that guides how we make decisions. And so there is going to be that bias when we're working with families. It doesn't mean that that's necessarily that we come up with something different than maybe somebody else who looks at the same situation, or that we have 3 problems and we put a problem that somebody else put 3rd, we move it to the top and feel like we need to work on that first. The important thing is that you have a real reason for why you're doing what you're doing, and that you have a plan for follow-up. And that's one of the things I really like about the PES statement format, is that we can define a problem, we can tell why we think it's an issue, and we have clear, defined, measurable pieces of information that we can use to follow to see if when we make a change, does that objective data change? So we have a way of evaluating. So that being said, don't be afraid to have something different than somebody else. All right, so I'm going to go back to where the case is up there so you can work with that. Okay, you guys ready to take a stab at it? So what did y'all come up with? And again, I'm not the keeper of the knowledge. I'm just the facilitator. So from anyone in our audience out there, phone or webinar audience, want to take a stab at a couple of PES statements using our diagnostic terminology? This one's kind of a tricky one. I almost didn't put it up here because there's all kinds of stuff in here. Don't make me call on you. I know who you are. All right, Elizabeth. I know you won't mind. Kirsten Watts, I know you won't mind because you do this all the time. Take a stab at a couple PES statements here. Have we muted them permanently, Kevin?
I know Kirsten, she has to be muted because she's
in the middle of something.
There's a lot of noise around her.
Okay.
So she may chime in over the chat feature. Elizabeth, I'm not sure. If you are muted, you might try hitting *#.
Can you hear me?
Yes, thank you. We can. And the answer is?
Go ahead and start over, Elizabeth. I think we were playing mute tag.
Okay, can you hear me?
We sure can.
Can you hear me? Oh, okay, all right. So, like I said, I have never done this, so I'm willing to jump in. Okay, so what I thought was restrictive eating practices or behaviors related to the fear of eating and the need to be fit, that was really not specified. You know, does he want to do like strength training and develop more muscle and, you know, all of that. Anyway, so I just wrote need to be fit since I had no information. As evidenced by decreasing BMI. And again, I'm a little puzzled by the decreasing growth velocity, which to me refers to height, which is we don't know. It doesn't say. We know that his BMI is lower, but we don't know if his height, if his rate of growth also decreased. So.
Yeah, and I didn't put the whole case up here, Elizabeth, just to make it simple, but there was quite a bit of growth data in this case, and actually all the things are dropping. I made the point with the BMI change, but all the growth parameters have gone from about the 50th to 75th percentile to basically where they are now. So that's good.
Yeah, so it's both his weight and his height. Okay.
Yeah, both his weight and his height. So which is, you know, I'm looking at both the 3rd edition and the 4th edition. So which diagnostic term did you use?
I wrote restrictive eating practices because I didn't want to say anorexia.
Yeah. So which is the number that goes along with that one?
Oh, I have no idea because I don't know where. I don't have that. I don't know where to look.
Okay. So
I mean, I don't have that information.
Oh, so that handout page with the terminology didn't get to you in the handouts?
Oh, yeah, no, I don't have it. I need to go look.
Okay. So there's that one piece, or there's the book. So, you know, one of the things that we can try to do is to figure out what's the closest to that particular diagnostic code. And so I had a similar one, Elizabeth, but I used under the behavioral environmental terms, I used disordered eating pattern. So the disordered eating pattern,
which is very similar. Yeah,
which is very similar, because I don't see one that's exactly the same, but it may be because I'm looking at a different code sheet. And then, so I think that's a good one. Where that's one of the ones that you can work with. All right, does anyone have a different one that they want to share? Courtney and
I have from Kirsten Watts.
Uh-huh.
Inadequate energy intake related to limited food acceptance
that's what I have.
and food aversions as evidenced by intake of approximately 72% of estimated needs.
Uh-huh.
And not great PES, but it's something.
No, that's good. It's fine. So you guys had something
Inadequate oral intake and limited food acceptance is what I wrote down.
Okay.
Yeah.
Okay. That's good. So I would think probably, combining those two, we basically are getting at the same thing. One is that this person has inadequate energy intake or disordered eating. It's evidenced by the information we got from the family, but also from the assessment where we have a change in growth velocity or report of self-restriction, that kind of thing. And the signs and symptoms are that intake that's less than what we would estimate that the child needs. All right, so we all agree on that?
Yep.
Good. So it's easier than it looks. The tricky thing is for us to get out of the habit, us meaning the collective group of dietitians, to writing everything longhand using our own words. After a while you get used to using these words, and I found that it to some extent speed things up a little bit because you're narrowing your focus. So we tend to be a little less long-winded, but you can see that we can have more than one. So then the trick is, if you're the provider, to figure out, once you've gone through this, what is it that you're going to start with the family and the child on first? What's the most important? All right, so here's our next one. Practice case number 30-month-old Hispanic male, a history of developmental delay, failure to thrive, and gastroesophageal reflux disease, constipation, and feeding difficulties. This child receives early intervention services. Currently, this child's weight is 10.4 kilograms, which is less than the first percentile, and the height is 90 centimeters, which is at the 90th percentile. This child eats pureed table food and takes Pediasure by bottle. His current intake from Pediasure provides about 75% of micronutrient needs and about 70% of estimated calorie and protein needs. The pureed food provides about 10% of estimated macronutrient needs. So macronutrient being fat, carbohydrates, and protein. No other liquid than Pediasure is consumed. And again, it's not a perfect case. Sometimes, though, this is what we get. So we have to come up with, not that we wouldn't want some more information, but given what we've got, let's take a stab at a couple of PES statements here, or more if you think it's appropriate. Okay, anybody want to take a stab?
Hi, this is Lisa Moser. I'll give it a shot.
All right, excellent.
Okay, I think there could be two potential ones here, but I put down underweight related to feeding difficulties, inadequate calorie and protein intake as evidenced by weight less than the first percentile.
Okay, so which is the number? Just so I'm finding your diagnostic code. See, I learn all these things.
It is NC 3.1.
NC 3.1. Okay.
Underweight.
Okay. All right, excellent. Do you have another one that you want to share?
Well, I thought that possibly, depending on how much Pediasure the child is taking, because they had that statement there of no other liquids, but I wasn't exactly sure. Off the top of my head, the fluid needs for a 30-month-old, so it could be inadequate fluid intake.
Yeah.
Okay.
And I 3.1.
Okay, so that's what you came up with, Courtney?
Mm-hmm. And protein, yeah. I had all three of those things.
Okay.
Inadequate protein, fluid, and
underweight.
And underweight.
And underweight. Okay, so you have some agreement there. And so what I tried to do is make these cases so we aren't all madly, pulling out our calculators. So if you look in the current intake of Pediasure provides more than 75% of micronutrients, but between the Pediasure and the solid food, you're only getting 80% of estimated needs. So that was sort of a way to get at that fact that he's probably not getting as much calorie or as energy and protein as we would expect based on estimated needs. So that was kind of a soft way of doing that without having us to do all that math. Okay? Any other ones out there? Because again, there's a lot of ways that you could look at this.
From his history too could fall under poor nutritional quality of life, I guess. I don't know.
So one of the ones that I did was inadequate oral intake,
right.
And I based that on the history.
Right.
So the etiology being the feeding difficulties and developmental delay, and the signs and symptoms being 80% of estimated needs being met from oral intake. And also the fact that you have the weight less than the first percentile. So that's another way of pulling in that history. And again, none of us are wrong. We all agree that this kid's got all of this stuff going on. So it's just a matter of getting ourselves into the habit of using the words that the Academy has decided that we're going to use to describe these problems. So that when we talk about inadequate oral intake, or if we talk about inadequate energy intake, or if we talk about underweight, that we're all very clear in our minds, what the definition of those things are. And that's the value of the book, because actually if you look at each one of the diagnostic codes has a page that tells about how that's actually defined. But it sounds like we're all pretty much clear about that. The other point that I wanted to make is that when you start to use this terminology, one of the things to think about is to focus first on those things that are completely within the control of you as a nutrition provider to impact a change. And that means, since we are the food professionals, that we should, as much as we can, focus on the intake domain. So look there first. Doesn't mean that it's not going to be related to other things, but that's a really great way, especially with new providers who are just getting started in their practice. That's the thing you know better than anybody else's food in all its forms. Whether it's pureed or frozen or canned, or it's Ensure, or it's a tube feeding, or it's some mix of things that you put together or the families put together. We know food better than anybody else. So starting there, and again, it's not that these other things aren't going to come into play, but that's a great safe place to get going with using this terminology. And you'll see that some of them are related, so I think it's nice that you can talk about inadequate oral intake, and then you could use, say, under the behavioral and environmental, You could say food and nutrition related knowledge deficit as your etiology, because you might actually find that they have inadequate oral intake because they don't know that they can do something different or that there are other options. So that's a way of tying some of these things together. All right, let's try another case. One more case to torture you all with. So this is an 8-month-old female named Samantha. She takes breast milk in a bottle at daycare, and she nurses 2 times a day, in the morning and evening when her mom, before and after work. All her growth parameters are consistently between the 50th and 75th percentile and have been since birth. She at 8 months is sitting unsupported. She's beginning to crawl, so she's getting up on all fours. She will eat some finger food. So at the end of the day, Samantha is fussy when her mom picks her up from daycare and she wants to be held. The 3-year-old sister, who's also at the same daycare center, is immediately hungry and she wants to eat. So mom, as soon as they get home, prepares dinner. So there's this rush from daycare to home to feed the 3-year-old sister who's throwing a fit. Samantha refuses solid food at this time and dislikes the high chair. Mom thinks the child is hungry and would be less irritable if she ate dinner. So this is a slightly different approach. So let's see what we can do with this one. All right, anybody want to take a stab? And this is why we're doing this in pediatrics, this kind of a case, because if I told you that this was an 18-year-old female who was refusing to eat dinner, it might be easier for us to use this terminology because we could have a conversation with the 18-year-old and maybe have a little bit more information. But the fact that it's an 8-month-old and she's not going to be able to tell us exactly what's going on, it makes it a little trickier. All right. Stunned silence. Let's try it.
I'll give it a shot. I'm a little bit rusty because I haven't used this in 5 years, but I'm going to say self-feeding difficulty is related to avoidance behavior as evidenced by refusing solid foods and irritable behavior.
Okay. Good. And you notice we're not talking about how to fix it at this point. We're just trying to name the problem. But one of the things is sometimes when you name the problem, then it gives you a path of where it is that you want to go. Anybody else?
I put limited food acceptance related to refusing solid food as evidenced by patient taking breast milk and will eat some finger food.
Okay. And just for those people who may not have their code sheets in front of them, when you use the limited food acceptance, which number are you looking at? So that people can find.
Is N1 2.9.
Did everybody find that on their list? Mm-hmm. Okay. All right, good. So again, we're not at this point trying to fix it. See, we could come back in another session and decide what our intervention is going to be. You know, whether it's support for the mom or support for the child, but at least we've named the problem, okay? And we have an idea of why we have that problem, and then our intervention could be something different at that point. So it's good. All right. Oh, I forgot. I gave you one more case. We have time. All right. Got to do one more. 7-year-old male, Timothy. His BMI is 20. That puts him at greater than the 95th percentile. Height is 52 inches, so that's between the 75th and 90th percentile. His weight is 77 pounds, which is at the 95th percentile. He's in 2nd grade. After school, he watches TV with his babysitter or plays video games. He has high-calorie snack foods available after school with the babysitter. The mom is obese. Dad is normal weight. The dinner is prepared at home. It has a meat, vegetable, starch, and dessert. And after dinner in the evening, he watches TV with his parents and he has an ice cream snack before bed. So let's take a stab at this one. All right, anybody want to venture a diagnosis here?
I put the NC 3.3, overweight, obesity, related to low physical activity level, high calorie snacks as evidenced by BMI for age greater than 95th percentile.
Yeah, that's great.
Exactly what I have.
Is that exactly what you have? Anybody else have anything different?
Yeah, I had obesity, overweight, related to excessive energy intake and sedentary lifestyle as evidenced by BMI over 95th percentile.
Okay. So that's an example of using, some of the terminology as the etiology. I had something similar too. Just played around with undesirable food choices related to high calorie snack foods after school, as evidenced by that BMI of greater than 95th percentile. You could also use the physical activity and function section of physical activity, evidenced by no planned activity and TV and video games after school. So, you could kind of come at it from multiple ways, and none of those things are wrong. I like the first one though because it really gets at probably why we got the referral in the first place, is because this child's BMI is over the 95th percentile. But again, it doesn't speak to how we're going to intervene at this point, but it gives us an idea of narrowing things down. And I think the sort of exercise for ourselves here is getting us to think in a more focused way and realize that there may be multiple problems here, and that each one of those diagnoses might have to be approached separately. Sometimes it might work for everything, but I think that the thing that I've gotten out of trying to adopt this terminology is that it might help with picking the thing that I'm going to work on first and realizing that there are multiple things going on and that I can't do it all at once. Because one of the things that we want to do is we want to fix it all at once. And that's just not the way of things most times in medicine. All right, so if we went back to that first question is, if you've been using this, how has it changed the way you practice? In other words, has it changed the way you do assessments and diagnoses and provide care to the children and families you work with? And secondly, if we have complete adoption, and if your site and your clinic and your hospital has complete adoption, what would complete adoption look like? So go ahead and give me some answers. Tell me what you're thinking. Questions, comments, interpretive dance? We're the only ones on camera, so. All right, well, I gave you my opinion. I think it's helpful for me when I work with students now, because it really narrows down the focus of trying to take a very complex case and putting it in some kind of format that you have an idea of how you're going to approach that with the child and family. Did you get someone?
Question from Kirsten Watts, actually, is do you know anyone who's using this in New Mexico?
Yes. VA uses it. So realizing though the VA is an adult hospital, so they use it exclusively. And part of they were one of the early adopters, and they have also, that system was an early adopter of an EHR. So it'd be interesting, maybe I can see if I can get a couple people from there to come over and talk about how they've incorporated that into their EHR. But the idea is that we want to get specific enough that these codes mean something, so that when we pull them out of a database, you know, pull them out of an EHR, we can get an idea of what practice looks like. The real reason I think of using terminology like this is to be able, for once in our, you know, whole Milo of career, work, and nutrition, is to be able to connect the dots. When this is the diagnosis, and this is the etiology, and these are the signs and symptoms, when we do this thing, these change. And you can actually then, in an EHR, be able to see a path of success or failure. So trying to figure out what works. And if everybody's using the same terminology, then we can start to line all those things up. People who have this diagnosis, who have these things done, have these kinds of outcomes. But we can't really do that if we're all using different words for things, because we don't know that we're talking about the same information. So I think that's one thing that would change. So the VA is using this. Again, that's an adult facility. And then Shannon Gregg, who's at Albuquerque Health Partners in Rio Rancho, I had originally asked her to do this talk just because she and I have had some conversations over the last year, and she's been with them a little over a year, and they are a level 3 patient-centered medical home, and they have an EHR that they've been adapting to a pediatric environment. And she was working with their IT people to put these codes into the EHR so that when she went in to actually do her notes for the patients, that she saw that she could just click on those diagnosis codes. So I don't know how well that's going, but I know that they've been working on it for a year. So hopefully one of these days I'll be able to get her to come in and talk about that. But those are the two systems that I know right now that are attempting to do this. Kirsten Watts, UNM is not doing this globally, correct?
She did respond that she was doing it, but to answer your question, no.
Okay. So it'd be great if we could, at least certain groups of practice, agree to, you know, take the plunge and do this.
Sounds like she does do it, but she's not allowed to use the codes in the EMR yet.
Okay. Okay.
Power chart.
Yeah. So does that mean that Kirsten Watts, that they're not in the EHR? Or could you put the codes in parentheses next to the diagnostic terminology so that at some point we could go back and search for those?
Her answer is no. There is another response from Diane Phillips.
Uh-huh.
The Indian Health Service has incorporated the IDNT into their EHR.
All right, excellent. So Diana, are you in a place that you can't talk to us, or you prefer to chat? Because it'd be nice to hear your opinion, seeing as that you run all of these telehealth programs for IHS and you've been in practice for a while.
I can talk. Am I unmuted?
No, we can hear you. That's great.
Oh, okay. Yeah, so we've incorporated into our EHR since the first version came out, and we keep updating it as the terminology changes. We've gone back and forth with whether putting the coding in or not. I mean, it's there, but it's kind of hidden. So it's there in case we need it, but it doesn't view in the note. But however, with our system, if it's put into in our note format, it's not really captured anywhere. So you know, it would be kind of meaningless, I guess. So we have investigated putting nutrition data into another portion of our EHR where the data would be captured, that we could query it later on. We just can't query out of our note in EHR.
So, you know, how's it working for all the providers that you are they pretty accepting of using the terminology? Do they find it easy, difficult, useful?
We provide continuous training on it, and you know, it's a little of each. Some love it, some hate it. You know, it's just something new, and it's just getting used to a change. I mean, and Lisa's on the call as well. She's from Indian Health Service, so she could comment on what she thinks.
Oh, hi, yeah, I'm on. Yeah, I'm not sure about those codes, how it works. We have a standardized template, and in our note, it doesn't show the code. What we've developed is just some certain nutrition diagnostic terminology that we commonly use, and then there's a space for free text, so if there's one that we don't commonly use, we can type it in, but I'm not exactly sure how the codes work in our system.
But what do you think people's acceptance of using the terminology is?
I think it's been really well accepted. And I agree that it does make our notes more concise and kind of pinpoints the focus.
And I think once dietitians get used to using it, I think they really like it. It's just the whole learning process. And we do a few trainings a year for our entire staff on using our template and the terminology. We usually have 2 or 3 trainings on that.
So what do your trainings look like? How are they structured?
We have a few different ones. So we have one that we usually go over. We have like a basic, so like an introduction to the nutrition care process and the use of the terminology, and we usually have case studies, kind of like you guys are doing. Probably go into a little bit more basics on the nutrition care process, and then we have a more advanced one that we take it to the next step and how to implement it into our electronic health record, and actually kind of taking a case study and then actually charting it into our chart and where we would chart and where we go into the different fields within our EHR to do that. Sort of gets incorporated into a little bit on the billing part of it too. Just we cover proper documentation for billing too. So usually it's usually webinar format, and we try to have it be interactive.
Okay. And do you find
usually like a live? Oh, I'm sorry.
Okay. Okay. Go ahead. I didn't mean to interrupt.
Oh, and usually the way our EHR works, we can kind of sort of do a note but not have it showing, and so we can actually, it looks like we're going through and doing it live, but we already have it kind of pre-populated, so we actually kind of go through the exact process with people.
So do you find when people come to your system, new providers, I'm thinking especially the ones who just out of their training, who just finished their internships, have they had good exposure to this in their training program so that they're pretty comfortable with this?
Yeah. The new dietitians are definitely more comfortable. It's the, I guess, more seasoned ones that we have a little more difficulty with, or just taking longer to adjust to the new system, I should say. But yeah, the new dietitians all know it.
Yeah, we have interns at Phoenix Indian Medical Center, and it seems pretty easy for them.
Yeah, they didn't learn it the old way, did they?
No soap notes.
It's the old fogies like me who have a hard time. All right, any other questions, comments, observations? All right, anyone who didn't announce themselves that would like CME, CEU credit?
I don't think I announced myself initially because I got on a little late. This is Diane Phillips.
Yeah, same here. I didn't announce myself either at the beginning. Lisa Moser.
Glad to have you both. Glad to see you're back in the telehealth world, Diane.
Yeah, I got diverted for a little while, so yes, I'm back. Or I'm in a different location, so I have a little bit more flexibility again now. So I'm trying to spread the word over. I'm in Navajo area now, so.
Oh, good. Yeah, I got your email, so hopefully you'll be getting some packages from us with some goodies in them.
Okay, great. Thank you. Thank you.
All right, anyone else? All right, thanks so much. We have no official cases today, so unless you have additional things you want to talk about, we'll go ahead and sign off a little bit early today.